Welcome to DHR Health Talks, the official podcast of DHR Health, where we open the mic to our physicians, specialists, and healthcare leaders to discuss the latest in medicine, wellness, innovation, and everything in between. I'm your host, Dr. Dan Gilla. Today, we'll be exploring chest pain and coronary interventions. Whether it is mild discomfort or a serious condition, understanding the causes, symptoms, and treatment options for chest pain is critical to preventing life-threatening heart events. Joining us for this important conversation is Dr. Christian Avalos, an interventional cardiologist here at DHR Health.
Welcome to the podcast, Dr. Avalos. You're no stranger to the Rio Grande Valley. Please tell us a little bit about your training and the care that you provide here at DHR Health.
Yes, of course. Well, first of all, it's a pleasure to be here. Like you said, I'm not a stranger to the Valley. I was actually part of the second class of internal medicine residents, UTRGV with DHR, and also part of the first class of cardiovascular fellows. So I did my cardiology fellowship here. I went on to Michigan for 1 year to subspecialize in interventional cardiology, which is what I do here. I've been here for about 2 years now since graduating from my training, and I've been loving it, every aspect of it.
So what does a fellowship in interventional cardiology provide you with that a regular subspecialty in cardiology does not?
Yes. So any sort of interventions to the coronary arteries, what that means is if you have a blockage, a plaque, anything that requires opening up within the coronary arteries, that's what interventional cardiologist does. That they fix that. The typical example I like to provide to people is the patients that go to the ER for a heart attack. They don't call it just any cardiologist. They call an interventional cardiologist, somebody who can immediately take that patient to the cath lab and open up that blockage because there is a 90-minute window.
So you mentioned the cath lab. Can you describe what a cardiac catheterization is?
So I want to clarify, a cardiac catheterization does not involve surgery. There's a lot of patients that I talk to them about requiring a cardiac catheterization, and the first thing that comes to mind is surgery. It's not surgery. It is an invasive procedure that requires advancing a small catheter either through the groin or through the wrist to the heart, and it allows me to take pictures of the arteries of the heart using iodine. That way I'll be able to visualize the entire anatomy of the heart, the arteries of the heart, and see if there's any blockages, how many blockages there are, where are they, and how severe they are.
So sometimes through a cardiac catheterization, you see a blockage, but the blockage may not require actual surgery. And what are your other options if that happens?
If they don't require surgery, meaning if it's like an isolated blockage, an interventional cardiologist can fix it there at the time of a cardiac catheterization with balloons and stents. The balloons are used to open up the blockages. The stents are used to anchor and maintain the artery completely open.
And can you describe a little bit more in detail what a stent is and if one is needed, how that procedure is done?
Yes. So a stent is, think of it like a metallic piece with medication built in to kind of clear out and treat that area that has a blockage. The complexity varies. You have some blockages that have a lot of calcium that are long. So what we need to prepare prior to putting a stent, it varies from patient to patient. A procedure can last as short as 20 minutes to hours. So really it's a case-by-case basis. But for the most part, patients go home the same day. It's an in and out procedure.
And does a stent look a little bit like a tiny spring?
Yes, it's actually it's a very tiny spring. It stays there. Once it's implanted, it stays there for the rest of your life. There's a lot of patients that ask me, so when is the stent going to be removed? They're not removed. They stay there for life to keep that artery open.
And what are the symptoms that a patient looks for in coronary artery disease?
That's a great question because symptoms vary a lot. The typical symptom is chest pressure, tightness, but especially in women, elderly with diabetes, the symptoms can be very typical. Even a simple, what you may think is gastritis, can be actually angina or a heart attack that's evolving. So there's a lot of patients that I see in the ER with, they were reporting maybe some burning sensation, some indigestion type of symptoms. And because they persist, they go to the ER and actually turns out to be a heart attack that I have to take immediately to the cath lab and open up a blockage.
And what studies are available to help evaluate chest pains and help diagnose coronary artery disease?
So in the outpatient setting and in the clinic, simplest test is a treadmill stress test. But the first thing we do is an EKG. That's how all the patients that go to the ER with chest pain, we do an EKG and see how urgent is this. Is this a heart attack or not? That's the first line. But in the clinic, we do a treadmill stress test. Patients walk, even run on the treadmill 5, 6, 7 minutes, can take a bit longer. And we monitor their symptoms as well as a cardiac monitor to see if the electrocardiographic findings change at peak exercise. There are some patients that are unable to tolerate treadmill, either amputation or wheelchair bound. So in those cases, we do a nuclear stress test where they don't have to walk, they don't have to run, they're sitting down, they're laying down the entire time.
And when does a patient need open heart surgery and coronary artery bypass?
So when we do a cardiac catheterization and we are able to visualize the entire anatomy of the coronary arteries, and we see that there's multiple blockages, just extensive, multiple arteries are affected, and the locations are very, very high risk to put a stent. In other words, if we were to put a stent there, there's a risk of another artery shutting down. In those cases, open heart surgery will be the best option. It would just not be reasonable to put stents throughout the entire arteries if it's extensive blockages.
And does it matter if it's more than one artery or two arteries? Does that make a difference?
Well, usually if it's an isolated one artery, stents is usually the option. But again, it all depends also the location. If it's, for example, at the beginning of an artery and where there's risk of shutting it down or compromising another artery, surgery can still be an option. But for the most part, if it involves multiple arteries, that's when we start thinking about open heart surgery.
And what kind of lifestyle changes can a person make to help reduce their risk of coronary artery disease?
So patients should always be checking or monitoring their cholesterol levels, blood pressure, if they're diabetics, their sugar levels with their primary care physicians. That's the importance of these routine follow-ups and closely monitoring their labs every 3 to 6 months. Because all of those factors, if they're uncontrolled, can lead to cardiovascular disease and heart attacks and strokes and heart failure, among other things. So the other things to watch are their diet, physical activity. One thing I like to recommend my patients is the intake of sodium. Decreasing their intake of sodium lowers the blood pressure. So it's a great way to better control the blood pressure as well as avoid increasing the dose of a blood pressure medication or adding additional blood pressure medications.
And what should someone do if they have a strong family history of coronary artery disease, especially early onset, or also if certain genetic markers are positive in their blood work?
Yes. So these patients should definitely have a cardiac evaluation, even if they don't have any symptoms. I mean, just having a strong family history or those genetic markers already predisposes them at risk of having a cardiovascular disease or heart attack. The simplest test to do, I mean, if there's genetic markers involved, it's additional other studies that are a little more specific. It varies from patient to patient or the condition. But the simplest test to do nowadays to kind of screen for cardiovascular disease in patients who have multiple family members without symptoms is a simple calcium score. It's a CAT scan, just one snapshot of the chest, takes less than 30 minutes, and it quantifies the amount of heart plaque in the arteries of a patient's heart. It gives a number between 0 and the thousands. The higher it is, the more plaque burden there is, and that will need to be evaluated further. But if it's a 0, that means clean, nothing to worry about, gives you the peace of mind.
And at what point in that calcium score do you determine whether or not additional studies are needed?
So usually over 400, it's high risk. If it's in the thousands, that's where we need to investigate further, either with stress testing or a more detailed, more comprehensive CAT scan involving iodine that illuminates the arteries of the heart.
And why should patients choose DHR Health Institute?
They should choose DHR Heart Institute because, I mean, we have all the latest equipment when tackling different coronary blockages. As I was mentioning to you, it varies patient by patient. What we need to do before putting a stent depends on the morphology of the blockage. But whatever it is that we're tackling, we have the equipment to provide a good stent placement, whether it be requiring, think of it like little drills that kind of drill through with a plaque, laser. We even have balloons that have built-in medications where we don't even need to put a stent. So we have all the latest equipment to tackle anything. We have imaging that we can use inside the arteries to visualize the plaque a lot better, identify the morphology, the size of the artery. We have all the equipment necessary to tackle pretty much any blockages.
And before we wrap up, is there one key message you'd like to leave with our listeners when it comes to taking care of their heart health?
I think, the most important thing is prevention. I am an interventional cardiologist. I love what I do, fixing blockages here and that. But if it's something that we can prevent it and we can save a life, that's the best we can do for the patient. So most important thing is prevention. Following up with your family doctor, following up regularly with your cardiologist, even if you feel like you feel good, you don't have any symptoms, because prevention screening is key. So I advise patients to regularly check their cholesterol levels, their sugar levels, check their blood pressure at home every now and then. And if you have strong family history, go see a cardiologist, get yourself evaluated.
Thank you, Dr. Avalos, for sharing with us your expertise on chest pain and coronary intervention.
Of course, my pleasure.
For our listeners who want to schedule an appointment with our DHR Health Heart Institute, you can call 956-362-8810. Thank you for joining us on this informative DHR Health Talks episode. Stay well, stay informed,
and remember, we are DHR Health, for you, for life.